thank you everyone for the pleasure being here. So I wish we would treat plants and not humans, so it's much more complicated, I think. So we are from Switzerland, University Hospital of Bern. It's the biggest of the 5 university hospitals in Switzerland. And so we are responsible for health information data, so building different pipelines, data products for medical decision support and research. And I would like to present you 2 use cases which actually illustrate the messy data we have to work with and also how we try to bring some clearness and understanding in there. So first case is about drugs. So I'm unfortunately from the pharmaceutical people, so it's a bit, I think, no-brainer. So of course we need medication and we need to understand how we use it in a hospital. So this case is about multi-drug resistant organisms. So it's a huge problem in the hospitals. So we are facing a lot of resistance. So we had one big outbreak 6 years ago with vancomycin resistant enterococca. So it's a real problem. And what hospitals do, so they start up stewardship, antibiotic stewardship, so actually to mitigate the risk of creating more resistance, so and really try to treat risk infections and also try to reduce the risk for patient to get these microorganisms. So microbial stewardships, it's a strategy which is multi-layered. So we have, of course, first is responsible use of antibiotics. So it still have some in reserve. So for people who really have a bad chance to get this drug, so there is something we can give them. It's also process measurements, so evaluate if the if the interventions we implement are effective. So we review compliance. So do physicians actually prescribe medication as they should do? Outcome measurements. So how effective were the medications? So do we really have impact on resistance? Also utilization metrics, so how many of medication was administered. And of course, we need also patterns of prescribing. So do we have different policies in different clinics? So where to put attention to enhance training and usage of antibiotics. And of course, research. So it's also important part. So how do this medication work on the real evidence? And all this is, of course, only valid if we have good data. So what we built a couple of years ago is antibiotic consumption report. So it's built for all administered medication in our hospital. It's really on the atomic level. So each administered drug, each dose is a singular data point, which is then aggregated on the patient level, clinics level. So we use ATC code. This is anatomic technical classification, which is really, really high level. So it's not really about a single medication, but it helps us to track the different categories of antibiotics. So you see this decrease in 2024. So is it something happening in our hospital, this decrease in consumption? No, it's not a decrease. We introduced a new electronic health record system. And actually, this change of system caused this decrease in representation. Of course, not in the usage. So we just don't know what's going on. And why is it happen? So I brought one example. So maybe it's like only one medication, but to show you which different system and different sources we use for to pull together the information we need for monitoring and implementation of this program. So I took the example of ceftazidime, avibactam. This is first, it's a combination medication, so there are 2 substances. And it's explicitly reserved for treatment for multi-drug resistant infection. From the logistics system, regulation, distribution, we get this information. So if we buy this product, our hospital pharmacy put it in a system. So we have the description of the medication. We have also ATC code, which exactly describe the substance. We have also the quantity of the substance in this product. And so first, it's also different brand name in Europe and in USA. So we have also here a first difference in actually description of this product. Of course, a different registration authorization in Switzerland, which is also might be different from the European Union. The second thing, we have treatment guidelines, which are introduced by our infectious disease department. So they give guidelines. This is online, this is PDF, so it's free text. So they actually give advice at which situation it's good to treat patient with ceftazidime avibactam. But there is no terminology there, so it's just free text. So you can consult this. It's of course available, but it's no linkage to the treatment itself. And we also get a report. So our university published report of the local resistance profile for all microorganisms which are known and tested, like current days, weeks, and months. So we know if we have this microorganism, it's high probably that it's resistant to some types of medication or not. So it's also a free text available, but you can consult it. The third thing, we have resistancy testing. Of course, people, if there is a suspicion that patient might have multi-resistant drug infection or a carrier, there is resistancy testing provided in a lab. And the results come back to our hospital. They're also in free text. So if resistance is detected, it's of course available in EHR, but it's not standard terminology behind it. And the same, we put this information in our clinical warehouse. We tried like post hoc, map it to standard terminologies as a SNOMED CT, for example, and a substance to ATC. So this comes together in our clinical data warehouse. And now the medication administration in EHR. So there is a custom-made catalog in our EHR which just contains the name of the medication and dosage. So you also might sometimes problems to have ATC code linked to it. And this master file is not always updated, so there is some ATC but different products, so it's a lot of gaps in this list. So administration is documented based on EHR ID, and then you have information, so this prepared was administrated. So what information is clinically relevant? So first of all, we need an ingredient. So the most important thing is the ceftazidime avibactam and also the strength, so how many milligrams of substance were administered. So what is not really important is the brand name. And so this is actually something we not rank as the highest priority. So now we have all this information scattered in different sources and try to put it in one place, our clinical data warehouse, actually to do all these great things we want to do, process analysis, compliance to guidelines, and distribution of different resistancy patterns. So how to do this? And as you saw, we don't have real interoperability between these different sources, and information is scattered and stored in different formats. So how we try to solve this problem? Karen.
So in order to make all the information accessible from legacy data and the actual data in the new system, and also from the different sources we used for should use for monitoring, we decided to transform the medication data at our hospital, for example, from the free text custom list to RX norm. And that has, of course, as most of you know, many advantages because in RX norm we have mapping to other standard classifications, and also we have really every product represented in a very standardized way. But the disadvantage is that RX norm is in English. Of course, there's this European extension for the European market, but that is not complete and not compatible with the custom list we use at our hospital. So to support the mapping process and to transform all this data, we had to set up a framework which made it possible in the first place to translate, but in the second place to map to this classification. And we tried several approaches because we were not sure which would be the right way and which would get the best results for us. So we used an open source tool that is offered by the Observational Health Data Sciences and Informatics Initiative, called Usagi, that is working with term similarity, where you can upload custom lists or other classifications and have an auto mapping to standard classifications which are offered. And the second approach we took was to use an LLM model and work via synonym generation in English and then do the mapping. The Odyssey workflow has the advantage that standard classifications are offered. And you see here that for the two mentioned drugs, there's a representation already available, which should be the target. The LLM workflow was set up in a way that in the first stage, as I already mentioned, synonyms were created, which we needed because we had to overcome this language gap between German and English. And then in the second step, the mapping was conducted. We prioritized certain information that come with the products. Active ingredient was the most important information that should be translated and mapped in the correct way because it contains the clinically most important factor of a product we were working with. The results showed that the approaches worked in a different way and prioritized the different classes in a different quantity. And we see here for the example we talked about before, the result that we have one concept that was prioritized by the brand and the other one by the clinical drug. So we do have different results which were both offered in the RX norm catalog, but do represent a different level of information. And overall, we could show this for the whole mapping of the whole custom list as well, that the two models prioritize the different classes of the concepts in the mapping process. So in order to analyze where we had different results concerning the classes and where we probably also have gaps in the mapping, we represented everything with a graph, and that showed us very clearly how granular the mapping could be conducted using the different models, and also concerning the different products and ingredients. We had the gaps in the mapping sometimes concerned certain ingredient classes and were not distributed evenly. So in the end, we could show that for the different models and for the different RX norm versions, the extension and the standard version, and the different classes, we had differences in path length, which showed us that the proximity of the mapping and the granularity differed between the two models. So, and then we come to case 2, which is even more interesting, I think.
Yes, actually, to sum up, so now we have at least a possibility to analyze the quality of our mapping, and Neo4j was a really valuable tool to see the difference and why the difference is so big between different concepts. So actually, first you start to realize, as you have seen it visualized with a Neo4j graph. And now, yes, so it's really interesting. So it's about surgery. So we know that not so many people work on the surgery representation and the medical health data because it's really complex. And some of domains even don't represent, so are not represented in any system. So for example, the variation anatomy. So people are different and the anatomy is different. It might be really a lot of information lost, so which never stored this anatomic diversity, which might lead to different outcomes after surgery. The second thing is also variation in method and approach. So surgery is a sort of art, so people do operate differently, and there are different methods, and the choice of a method maybe it's also differs, so you never know why this method was chosen. Is it a guideline driven? Is it a situation driven? Is it a personal preference? So all this information is also not stored in the EHR standards, so it's really interesting to find out, is there influence on the outcome of the patients? And very important thing, surgeon personality. So we also have a difference in personality performing the operation and surgery. So even if it's the same standard operation, you might have a difference. It's just who is operating, which team, at which daytime, and you know, it's really very, very context dependent, and we still don't know what is actually the outcome. Now robotic is very important, so it's take more and more place in our planning, and also carrying out the surgery. So also to see these differences in the data, it might be really very, very important, interesting in the future. So we got a case, prediction of post-surgical infection. So we analyzed a lot of data pre-surgery, so patient characteristic like age, comorbidities, everything which is actually known before the surgery starts. Then intraoperative data, including physiological data, also urgency and the night surgery. And we also introduced the post-operation data using mostly kinetic of different labs biomarker. So in the end, we were able to predict infection pretty good on the second post-operative day, which is much better than actually decision outperform clinical-based decision making. But still, there is a question. This is a generic approach, but we are convinced that the type of surgery and invasiveness of surgery, of course, has an influence on the surgery outcome. So we would like to cluster surgery type invasiveness using a classification, so build cluster and see a difference between these different clusters. So the idea is clear, but the problem is that procedures classification are almost country or healthcare specific, so often not standardized, not in English. And mapping is always not available, so there are multi-axle, different abbreviation names and descriptions, really messy catalogs. In the majority of the world, they are really not well suited for standard analysis. And so what we did, we compared two classifications, one from Germany and one from Switzerland. They are already different. You see in the first glance. So one has 30,000 entities, there are not only 3, but German is only in German. In Switzerland we have French, German, Italian version, which are already different itself. So it's really interesting case. So we first developed LLM to translate this version into English, and also curate a synonym, so it's really a clear representation of the content. When they create this post-processing and create a graph and vector, so put it in the embedded environment, so we can also search on these vectors. This MapCare framework was one use case, and another we also used this ODC mapping for the manual validation and curation.
Yeah, and here again you see a similar approach. We used the ODC tool. We used SNOMED-CT as an interoperable classification as the link between the two source classifications. So we mapped the German procedure classification to SNOMED and also the Swiss classification, and evaluated then the target SNOMED-CT identifiers concerning the how to say this, similarity, yeah. And then we imported everything into Neo4j. So in Neo4j we visualized the mapping to OPS, to the German classification, as well as to the Swiss classification, and also integrated SNOMED-CT as the link to both. And also here, as similar to the medication mapping results, we could analyze gaps in the classifications and gaps in the possibility of mapping to standards, which made it possible to assess where we would have problems with interoperability between the systems, and where we also would have gaps when trying to cover our local procedure classification to a standard. So when we validated the results, which we had to do manually, we compared the accuracy and translation, semantic matching and mapping, and also compared the different translations of the languages, which was quite challenging, of course, with the Swiss procedure catalog, as we had 3 languages involved. And what we could show is that with this fully automated mapping by term similarity, we only got very moderate results. The manual validation showed that for an exact mapping, for example, to SNOMED-CT as an interoperable classification, there we had to do a lot of manual corrections and couldn't use the generated results as they came out of the system. But still, we had a good pattern of results concerning the languages in certain areas. So in the end, what we achieved was that we set up a system where we could handle the different languages and transfer our catalogs into the target language English. This worked very well, but the fully automated mapping process showed still limited results. The main goal which we achieved was that by using a graph representation, we could really access the mapping results in a very easy, accessible way, and that made it much easier for us to correct mappings and to also analyze the gaps concerning the target classifications which we needed for interoperability and standards. But the whole system, the whole workflow worked very well, and in the end it was possible to integrate it into the whole process in order to build up a monitoring. This is still what we, the results are still what we used in the project, so it's not really productive right now, but it's a good foundation to go on. And the whole system we had to build up was quite complex because we had to build it in a secure environment. Different tools had to be linked, open source tools, and also our databases, which we had to use as a source. What we achieved with this is that we really had a data pipeline that covered all our requirements. So in summary, it cannot be underestimated how a graph representation supports knowledge generation, but also the visibility of the quality of your work. And for us, the main achievement using Neo4j in this context was to have a high transparency of these complex processes and results, and to gain a deep insight into the potential of the systems we try to build up, and also to support a further development in the areas where we still have gaps. Yeah, I think that was it. Yeah. So this covers the key message, but we said it before. Yeah. Okay. Thank you. I think the time is over. Yeah.
Thank you very much. If you have any questions, use Slido, please, so that we can take the questions after.